Title of the talk, Open Standards in Health Data and Governance, a particular focus on what we're actually doing around the Datawell programme in Greater Manchester. So what is Datawell? Datawell is really about the sharing of information, particularly for the use of healthcare, and sharing of health data in something of a hot topic at the moment for all sorts of reasons, naming no names, but obviously with things like it's very much in the news in a way that it hasn't really been before this year. I mean, even in Birmingham recently, last week, the LMC overruled a local programme to build a data warehouse in their CSU. So, yeah, this is something that I think there's a lot of debate and discussion about what is right and appropriate in the way that we share information. And there's a sense in which we really have gone from the frying pan into the fire. Hence the picture. And the reaction that we get when we talk about data sharing is usually something like this. Patients haven't given consent for their data to be used like this, or to be used for this piece of analysis, or to be available to the clinicians in a different trust or different people. Patient expectations, however, are quite different, I think, to what that actually is. And I could have put up pictures of anything here, Facebook, everything else. I chose bank machines purposely because they're quite an old-fashioned technology. They've been around for a very long time, but they enable us to access our money wherever we are in the world. And on top of those systems now, we have the web-enabled applications and access to our accounts. We have Facebook, we have online flight bookings, all of which means that our patients' expectations are very different to what we're kind of trying to protect them from when we say that we don't want their data shared. Which means that our patients are now talking to us like this. I have a long-term condition, I go into hospital, the first question I get asked, what medications are you on? What drugs are you taking? It's like, well, if you don't know that as my doctor, then we're in trouble, basically. And if I'm not able to give that information because I'm unconscious or unwell or basically not able to do it, then the problem gets compounded. We do have methods for sharing data already available to us in the NHS, and some of them have been in use for quite a long time. This is an example of one. It's the yellow book that you use as a warfarin patient. You record when you've taken your information, you carry it around with you, and you show it to your doctor whenever you see them and say, this is what I've been doing. It's not really ideal from our point of view as informaticians, though. The data's kind of put in a bit of a black hole, we're not really able to access it. There's also something of an opportunity for error. I think one of my favourite things about this one is that at the top there it says, aspirin to be stopped when in range on a little tick box, and we hope that was all done in an adequate way, so we don't really know, but it's obviously it can be done. So we've got some way to go. In Greater Manchester in particular, and I think a number of the northern cities, we do have particular health challenges that we're also seeking to address, and it's maybe in order to address that we're probably going to have to look at some of the data aspects. So things like we do have higher deprivation. Obesity and smoking rates are very high. That leads to high rates of cancer, high rates of heart disease, all of which means that our hospital rates are higher, so everything's costing more, and we can't afford it because our deprivation's so high. But that means that we've got a lower life expectancy. And to put that into context, some areas of Greater Manchester, the life expectancy is 10 years lower than the national average. That's not acceptable. So we need to be able to use the data in order to be able to make a difference. And EHRs are probably not really the whole solution. We also know that better access to data means better care. And this is Snow from the 19th century, looking at cholera. It's become a very famous picture. I'm trying to stop using it because it gets used a bit too much nowadays. But this was really instrumental in us understanding the public health message of how cholera was being spread using the water taps in Victorian London. But a more modern example here shows where actually we can take that data and we can start to look at how we apply that to produce safer care in the modern system. And in this case, we're looking at information around basically the liver function test for patients who are on glitazones. And there was a shift from rosiglitazones to pioglitazones which is indicated by the break there. And not only is that visible, but we're showing actually that the liver function was continued to be safe. And we can feed that back to our clinicians and our patients if we're able to monitor it. But at the moment, the only way we can do this is through very expensive research. Even though it's an academic study, it still costs quite a lot of money. We need to make this more and more routine. So how do we do that? I think that really one of the things that we really need to get through is information governance, and we need to start thinking about what we mean in terms of standards and how we do make standards, how we compute, make them computable. And that's one of the main thrusts really for the Datawell program. It's not so much the data sharing. There are 100 companies here now that can do the data sharing piece for us. But what I don't think they can all do at the moment is give us that guarantee around how that data is being shared. And that's something that we need to understand in a bit more detail. And it's going to remain a challenge to access the data if we can't really solve this problem. At the moment, we've got it's almost like a video game. We have, governance and ethics. We have unclear processes that are opaque. They're not standardized. We're beholden to individuals' points of view about an interpretation of the Data Protection Act. We have an overly complex system. The data quality is poor. Ethics, do we even need it for some of the things that we're doing or not? How do we make that judgment call? Those standards and those decisions, those topics aren't there. So when we're playing the information governance game, we knock down one brick and there's still 10 more behind it that we have to try and get through. So what we've settled on is 5 core principles of what we're really trying to do in terms of Datawell. The first is, and the background here is actually from Caldecott 2 cover, so that's where we're drawing inspiration for this one, is that the duty to share information to ensure safe patient care is as important as privacy. And I think often we forget that when we're talking about the decisions that we're making that stop us from being able to share information, are we always clear about what the impact of that is on the patient? And therefore, what do we need to redress the balance on that? Secondly, patients must be able to access their own data. I'm staying away from saying that patients must own their data, because I think that actually I don't want to own my medical data any more than I want to own my bank records. But I do want to be able to see them. I do want to be able to access them. I do want to be able to know who else is accessing them and using them. And I want to be able to share those with whom I choose, especially with my health records. I want basically my carer to be able to see it. I want my surgeon to be able to see it. I want other people to be able to see it. And I want to be a part of that decision. And I also want to be able to enable that data to be available for research as a patient. Whether sometimes that's the big bad pharma, yes, but there's lots of research that goes on that could directly benefit me as a patient. And I want to make sure that I have the opportunity to contribute to that. Identifiable data, where I haven't given consent necessarily, direct consent, should really only be available within the NHS or within approved safe data havens. Yes, it should stay within the NHS, but we have to acknowledge we're living in a bigger world than that now. We have cloud computing, we have lots of benefits of cheaper access to compute than we ever have before. We need to be able to take advantage of that, and we need the standards designed to be able to do it. But we have to commit to saying, actually, identifiable data will only be that. But what do we mean by non-identifiable data is something that we haven't yet addressed. Data should only be shared through appropriate data sharing agreements. Hopefully none of these are particularly controversial. I was having a chat with an IG person just last week, and we were talking about how data sharing agreements are kind of being used as contracts now, and that's not really what they're about. It's sort of saying we're using them to say if you break this data sharing agreement, you will be punished, and that's not really what a data sharing agreement is really for. And that we need to actually think about what data sharing agreements are again, and and how do we make them computable? How do we ensure that a data query that's made conforms to a particular agreement, rather than thinking about them as being simply another piece of paper that we have to sign and that we can point to when something goes wrong to try and punish somebody. It has to be better than that. And the final one is that processes for governance and assurance need to be both standardised, but also we will commit to basically making this available for external audit. Whether that's penetration testing, security testing, or general audit over what we're doing and what's capable, we have to be able to do that. And we will commit, as part of the programme that we're doing in Greater Manchester, to that external audit on a regular basis. And that means being conformant with standards like 27001 and 9001 standards, and being able to show that we can do that. In order to achieve all of this, I don't think that data warehousing is the whole of the solution for all sorts of reasons. I think one of the reasons is that we have such a range of entities, such a range of organizations that hold data about me, that we can't simply put everything into one place. That's just not going to work. Those organizations aren't going to want to give up the control of their data because they have a legal duty to protect that data in the first place. Also, we have to recognize that there is a business value in some of that information to those entities, and they do feel protective about it. And they're putting a lot of effort into collecting it. So we need to find another way to share. We started mapping out what some of that environment might look like in terms of data sharing. And I'll point out it's data sharing here, so something like direct patient care, we've put into the opt-out bracket rather than the no consent required bracket, because we are talking about sharing. And I think the consensus, whether it's a legal obligation or not at this point in time, I think is up for debate, but the consensus at the moment is that opt-out at very minimum is probably required. But I certainly don't think it should be anything more than that. But the other uses, I think, where we're talking about, whether people should be able to opt in and whether you should have explicit consent for different processes might include things like clinical trials, device and drug safety evaluation. So when are we doing the appropriate mapping? The chart that I showed earlier about glitter zones, we need to be able to do that work as a part of the, in order to be able to understand that the drugs that we have are safe. We need to be able to do the epidemiological and the health evaluation work as well. But in order to do this, so I've kind of taken this from HSCIC, but where we look at something like anonymised data, what do we mean by anonymised? Now, the ICO is basically very clear. Anonymised means aggregated data. Well, that's not really that helpful necessarily. Are there other systems like k-anonymisation that we should be looking at and we should be making part of the standards for how we do data? But what's the acceptable risk? Because this is not a binary system. This is anonymised, this isn't. This is very much a system where we have to think, what's the level of risk that we're prepared to accept and acknowledge across what that data means? Which leads us on to Datawell. So, constructed the business case, it's all gone swimmingly well, and we're getting ready to really start to understand what, from a technological point of view, that's going to look like. But one of the things that we're convinced about is that it has to conform to those standards, and it has to be a secure platform for really enabling the use of electronic shared data and the use of that shared data within the context of data sharing agreements. It needs to be vendor agnostic. Obviously, what do we mean by vendor agnostic is not that the system has to be able to talk to other systems, and there's always going to be a certain amount of needing to build connectors and so on for all of that. But it's not just about the big people. It's not just about the Cerners and the Intels and the IBMs of this world. And it's about how do we enable access to information for the smaller companies, for the bright startups, for the ones that currently are looking at their 3-month build an app cycles and need the data to be able to test it and be able to validate it and be able to prove to us that actually their application is of value, which they can't do at the moment. So how do we support them? The other end of the scale, yes, we're going to suddenly hopefully have access to much larger, richer data sources than we've ever had before. And we're going to have to take advantage of the new informatics capabilities in order to be able to really understand that. And so it's no longer about your simple analytics anymore. We have to be getting into that dreaded big data space, and we have to be able to really understand how we're not just simply going to present a dashboard and hope for the best, but that we're actually going to really understand what kinds of change we need to effect in order to transform the system. We also need to record how the system's used. We need to record how the data is passed around. We need to be able to record consent. Consent has to be dynamic. Patients have to be able to withdraw consent where it's appropriate. And we have to be able to support patients' understanding of their own information and their own health. And that's through these systems using this platform to present that information back to the patient. What does it look like? Well, we don't know exactly yet, but it's probably going to look something like this, we hope. The big blue circles are basically what we're calling the nodes. So each site will have a node, because what we don't believe is, as I said, we don't have a big data warehouse, but each site, almost a sort of a unit of governance, like a hospital or a CCG or even a GP practice, will basically continue to own their data, but they will have a node that provides access to that data as part of a data exchange. On that node, behind it, you might have the local data warehouse, you might just have an Excel spreadsheet, doesn't really matter. But associated with that will be the electronic data sharing agreements that allow you to share information between one trust and another. But also to not do. So you might have information that says, okay, your hospital A's A&E department can access data from hospital B. But we're having a bit of a discussion, shall we say, about the delivery of cardiac services, and so we're not going to share this whole set of information. But suddenly that discussion has actually also become a lot more public, and it hopefully will promote a bit more of a transparent discussion about what data we are prepared to share as well. We also include nodes for research, potentially, and feed that information back in. Area of interest as well is around patient-contributed data. At the moment, data that a patient collects on their iPhone is not necessarily that easy to get back into the system. We don't understand it, we don't understand the quality of it. But if we can sort of match it to a patient and perhaps start to use it in different ways, that might help that process. The value to the system, though, is not just in being able to exchange the information, it's in how we use it. And to do this, we're looking at basically an accelerators program. So that's working with our localities, working with business, both big companies and SMEs, in order to identify the particular problem spaces that can be helped by sharing of information, and really building the infrastructure, building projects around these particular accelerators and programs to help us solve the problems along the way. Whether that's problems of governance, whether that's problems of data, the data quality or just access to, or whether that's what that platform and standards needs to look like, or developing new and innovative practice around how we do things. We do have some of those accelerators in progress at the moment, in particular around end-of-life care planning and atrial fibrillation. We're also looking at familial hypercholesterolemia and potentially also AKI, which is actually acute kidney injury, which is a relatively simple one, because really we just need to push around a single pathology result and do a bit of checking on it, and we should be good to go. So these are things that are relatively low-hanging fruit, we hope, that we can sort of pull off, and we'll demonstrate the value of what we're doing and teach us how we can start to understand more about what we need to do next. So those are that value and opportunities that we're hoping to unlock. And we need to develop those standards. They don't exist at the moment, not fully. Things like HL7 go a large part of the way, but I think there are things around the governance and just the processes that we need to have in order to be able to access data simply aren't there. So we're looking at what those need to be right now. We need to promote access to the information. We need to actually get the access to the information. In Manchester, all 30 of our health organisations have signed up to participating in this. That means that hopefully we can actually start to use that with them to actually bring them on board and get access to their data. Still a long way to go from that agreement to actually getting hold of the data, but at least we've got the acknowledgement that it's a worthwhile thing to do. Once we've got the access, we can then start to look at the design of the system. That's both design of the accelerators, but also design of the platform. What does that need to look like? What systems are out there that are going to help enable us to do that? What open source software might be able to do it? Certainly, I think the Hadoop's probably going to come into it at some point. And use that design to really start to run pilots. So that's where we start to partner with industry in order to basically make things cheaper for us to try out, and we really need to do that. And we need to be able to use those pilots then to evaluate what we've done and be able to really demonstrate, almost like a quali for informatics. Are we able to show that by sharing information we have made a direct impact on patient health, on population health? And if we can't do that, then it's very unlikely that there is a value to what we're doing. So we need to be able to do that. We need to transform how we do that. And as we're doing that, that then feeds back into hopefully developing standards as we go on. And that's really it for me. Photo credits, I'm legally obliged to put up. Thanks to Creative Commons. So really, it's just range if there's any questions about what we're doing, or if anybody wants to speak to me afterwards, I'm certainly happy to do so.